Welcome back to the deep dive. Today we are cracking open a truly foundational text, Gray's Anatomy, for a really comprehensive exploration of the chest wall and breast anatomy.
Right.
And this isn't just a list of bones, it's a structural map that is absolutely vital for clinical thinking.
That's so true. You look at the thorax, people often just think of it as this, rigid cage.
Yeah.
But that completely misses the point. Anatomically, it's a dynamic osseo-cartilaginous framework. You've got 12 pairs of ribs, the vertebrae, the sternum, all enclosed by some really crucial soft tissues.
So our mission today is to take this complex, layered environment and just distill it into a sharp, clinically relevant visualization.
Exactly, to give you that mental map.
So let's start right at the most superficial layer, the outer envelope of skin and fascia. We need to understand how sensation even gets here.
Okay.
The skin covering your thorax is supplied by cutaneous branches of the cervical and thoracic spinal nerves, and they travel in these overlapping, sort of curved zones, dermatomes.
And what's fascinating about that pattern is how quickly it changes. Up near your shoulders, the zones are almost horizontal.
Okay.
But as they descend, they curve obliquely inferiorly toward the front. But here is the critical anatomical irregularity that often stumps people. There's a huge sudden jump in innervation.
Ah, you must be talking about the T1 gap. Why does the map jump from, what is it, C3, C4 dermatomes directly down to T2, T3? It basically skips T1 on the trunk.
Well, it's because the body essentially rerouted a major cable. The majority of that first thoracic spinal nerve, T1, it doesn't stay in the torso at all.
It doesn't.
No, it hightails it right into the brachial plexus to supply the upper limb. So because T1 is preoccupied with your arm, it leaves this huge gap in the torso's sensory map. That's a key piece of information for anyone trying to trace pain.
That structural design has real consequences. And speaking of nerves in that superficial layer, there's one that often causes issues after surgery.
Oh, yes. That's the lateral cutaneous branch of the second intercostal nerve. It's widely known as the intercostal brachial nerve. It supplies the skin over your armpit, your lateral chest, and the medial part of your arm. And because its path can be so unpredictable, it's particularly vulnerable during, say, axillary or breast-related surgery.
And damaging it would cause what?
It's a common cause of chronic postoperative pain or strange tingling sensations, something we call paresthesia.
Right. So once we bypass that nerve supply, we get to the fascia, superficial fascia, which is where we find most of the fat. And of course, the breast tissue itself is pretty loosely attached. But there's a crucial extension of the breast tissue we have to highlight.
That would be the axillary process, often called the tail of Spence.
Exactly.
It's that superlateral extension of breast tissue that, and this is unique, it pierces the deep fascia to reach up toward the axilla.
So if you understand where that tail goes,
You understand where cancer cells can potentially migrate earliest. It's why imaging and surgical clearance must always account for it.
okay, now that we've peeled back those layers, let's get into the bones that define the framework, starting anteriorly with the sternum.
The sternum is that central, elongated bone, and it gives us the most important single landmark in the entire thorax.
And it's in three parts, right?
Three parts.
Right.
The superior manubrium, the long central body, and then the small, often variable rhizoid process at the bottom. But the point where the manubrium and the body meet, the manubriosternal joint, that's the sternal angle.
Why is the sternal angle so clinically critical?
Because that joint lies horizontally level with the T4-T5 intervertebral disc in the back.
Yeah.
That alignment is, well, it's the anatomical equivalent of a compass reading.
It tells you where you are.
It tells you everything. It marks the second rib, which is your starting point for counting ribs, the superior limit of the pericardium, and the plane separating the superior and inferior mediastinum. It's the most reliable piece of orientation in the chest.
And as a quick aside, the sternum is also functionally significant beyond just structure. It's got highly vascular, hematopoietic red bone marrow.
Yeah, absolutely, which makes it a common site for bone marrow aspiration.
Okay, so moving laterally from the sternum, we find the 12 pairs of ribs. The classification seems simple, but it's essential.
It is. Ribs 1 through 7 are the true ribs. They attach directly to the sternum. Ribs 8 through 10 are false ribs, attaching indirectly. And the last two, 11 and 12, are the floating ribs.
So let's visualize a typical rib. It curves around from the back where the head connects to the vertebrae, then you have the neck and the tubercle. But if you were a surgeon, what single feature on that rib shaft would you care about most?
Oh, that's easy. The costal groove.
The costal groove.
It's a literal protective channel that runs along the inferior internal surface of the rib. And this groove is where that critical intercostal neurovascular bundle vein, artery, nerve, or van is tucked away, shielded from trauma.
That groove is nature's armor plating, but not all ribs conform. Let's look at the atypical ones, ribs 1 and 12.
Rib 1 is it's broad and flat, and it slopes down and forward. Its superior surface is uniquely marked by 2 shallow grooves, and they're separated by the scalene tubercle.
And things pass through those grooves.
Critical things. The anterior groove carries the subclavian vein, and the posterior groove carries the subclavian artery and the lower part of the brachial plexus. Remember that VAN relationship from front to back?
That VAN mnemonic is a great clinical shortcut. And rib 12?
Rib 12 is dramatically shorter, and it lacks a neck or a tubercle, which makes it highly mobile. It's less about protection and more about being an anchor. It provides massive attachment points for the diaphragm, the quadratus lumborum, and some large abdominal wall muscles.
It's amazing how rigid the ribs look, but we know this framework has to move constantly for breathing. So how do all these joints allow for that?
That's where the joints become key.
Right.
Think of it as a stability versus mobility trade-off. The joint connecting the manubrium to that first costal cartilage, the first sternocostal joint, is unique.
How so?
It's a fibrous joint. It's essentially welded shut. It's built for pure stability.
Unlike all the joints below it.
Exactly. The joints for the 2nd through 7th ribs are synovial joints. They allow small gliding movements, which are absolutely essential for ventilation. And posteriorly, you have the costovertebral and costotransverse joints connecting to the vertebrae.
So this joint arrangement dictates how we breathe. The upper 6 ribs mostly rotate like a pump handle, right? Lifting the sternum up and forward.
Precisely. While the lower ribs, roughly 7 through 10, have a flatter articulation that allows them to swing outward, more like a bucket handle.
Which increases the side-to-side diameter.
It primarily increases the transverse diameter of the chest. This whole dynamic changes the infrasternal angle dramatically during deep breathing.
Moving from function to clinical problems, let's touch on congenital deformities, starting with the 2 main pectus issues.
The most common is Pectus excavatum, or funnel chest, where the sternum caves inward. While it's often cosmetic, severe cases can physically restrict the heart.
How does that happen?
Well, it can compress the right ventricle between the sternum and the vertebral column, and that can lead to cardiopulmonary dysfunction. Its opposite is Pectus carinatum, or pigeon chest, where the sternum protrudes forward.
And the most common trauma, of course, is rib fractures. If the sternum is so resilient, where is the chest wall most likely to fail?
The chest wall is designed with the weakest link. The rib is most vulnerable, just anterior to its angle.
Just anterior to the angle.
Yes. Traumatic stress, especially compression, concentrates right there, making it the most common site for a fracture. And it's a crucial clinical rule. The more ribs you find fractured, the higher the risk of severe internal injury.
Okay, let's go internal to the skeleton now and explore the musculature, which also comes in layers. We have 3 distinct intercostal sheets.
Yes. Starting superficially, you have the external intercostals. Their fibers run obliquely downward and forward. Think of putting your hands in your pockets. They span anteriorly.
And then deep to them, the internal intercostals.
Their fibers run nearly perpendicular to the externals, so backward and downward, and they stop posteriorly.
Which leads us to the critical layer.
The innermost intercostals. This group is variable, but its location is everything. It creates an anatomical sandwich because the intercostal neurovascular bundle, that VAN bundle we talked about, runs precisely between the internal and innermost layers.
That anatomical sandwich is a perfect way to visualize it. And we have other intrinsic muscles attached to the internal surface, too.
We do. The transversus thoracis is on the inside of the anterior chest wall. It's important because it helps separate the internal thoracic vessels from the pleura. And then you have the serratus posterior muscles. Their primary role isn't really power ventilation.
What is it then?
It's thought to be proprioception, basically telling the brain where the chest wall is in space as it moves.
And knowing that precise layering has revolutionized pain control, hasn't it? We can target specific planes.
Exactly. Modern pain management uses fascial plane blocks, like the transversus thoracis plane block. We are intentionally delivering anesthetic right into those planes to maximize relief after surgery, blocking the nerves right where they run.
Let's dedicate a moment to making sure those neurovascular safety rules are crystal clear. You said the costal groove protects the VAN bundle, but where exactly is it in the intercostal space?
Okay, if you imagine the space between 2 ribs, the intercostal vein, artery, and nerve van course along the superior border of that space. Specifically, they're tucked just beneath the inferior margin of the rib above it.
Superior to inferior, vein, artery, nerve.
Always. Vein, artery, nerve.
And what are the major arteries that supply this whole region?
They come from the front and the back, Anteriorly, you have the internal thoracic artery branching off the subclavian. It gives off perforating branches, and the second through fourth are key suppliers to the breast. Posteriorly, the posterior intercostal arteries arise mostly from the descending thoracic aorta.
So the location of that van bundle dictates the single most important safety rule for any procedure involving the chest wall, like a thoracocentesis.
Absolutely vital. Draining fluid from the pleural space, thoracocentesis, must always be done by inserting the needle along the superior border of the rib below the space.
So you aim for the top of the lower rib.
Exactly. If you go near the inferior border of the rib above, you risk hitting that vulnerable van bundle. It's a never event.
And while it supplies the chest wall, the internal thoracic artery has a life far beyond the thorax, doesn't it?
It does indeed. It is often the vessel of choice for coronary artery bypass grafting CAG because of its excellent long-term patency rates. It's just a very robust vessel.
Finally, let's turn our attention to the specialized region contained within this framework, the breast. Anatomically, it's a wide area, generally from the second or third rib down to the sixth.
Right. And the functional unit is the secretory lobules, which feed into about 15 to 20 lactiferous ducts.
But structure and support are key here.
They are. The glandular tissue is held up by layers of superficial fascia and, crucially, by the suspensory ligaments, or Cooper's ligaments, which anchor the tissue to the skin itself.
And deep to the breast is the retromammary space.
Yes, a layer of loose connective tissue that allows movement over the deep pectoral fascia.
And that space can be a diagnostic signal, right?
A huge one. If carcinoma is present, that loose tissue can be invaded, causing the breast tissue to become fixed or tethered to the underlying muscle. That's a significant clinical sign of advanced disease.
Now, the lymphatic drainage system here is the single most important concept for breast cancer metastasis. It determines everything.
This is non-negotiable knowledge for anyone in medicine. Over 75% of the lymph drains predominantly to the axillary nodes. And surgically, these are divided into 3 levels based on their relationship to the pectoralis minor muscle.
Level 1, 2, and 3.
1 being lateral, 2 posterior, and 3 apical or superior.
What about the remaining lymph that doesn't go toward the armpit?
That drains medially to the peristernal nodes, which run along the course of the internal thoracic artery.
And why is that pathway so significant?
Because lymph vessels there can communicate across the sternum, providing a direct route for potential spread to the opposite, or contralateral breast or nodes if the tumor is located medially.
And just quickly on variations, we sometimes hear about extra nipples or breast tissue.
That happens along the embryonic mammary ridges or milk lines, which run from the axilla down to the inguinal region.
So it's a developmental remnant.
Exactly.
Yeah.
Polythelia, which is supernumerary nipples, and polymastia, accessory breasts, are just manifestations of tissue developing along that old ridge. And the male breast is rudimentary, mostly just ducts. Gynecomastia is just the benign proliferation of this tissue.
We've covered a massive amount of territory and connected structure directly to practice. To recap the most crucial takeaways for you listening, remember that critical T1 innervation gap, the essential landmark of the sternal angle at T4, T5, the protective costal groove, and that absolute safety rule inserting needles along the superior border of the rib below to avoid the van bundle.
And to tie it all back to the dynamics, the thoracic framework is not uniformly stable. Think about the difference between that immovable fibrous first sternocostal joint and the flexible synovial joints of ribs 2 through 7. That structural variance is what gives you the essential range of motion for life-sustaining ventilation.
This leaves us with a final provocative question for you to consider. We established that the ribs often fracture at their weakest point, just anterior to the angle, while the sternum is comparatively resilient. So given that the chest wall is designed to protect your most vital organs, what does the inherent elasticity provided by the costal cartilages, those highly flexible anterior attachments, reveal about the true dynamic function of the chest wall under massive compressive trauma? And how does that elasticity contrast with the structural failure we see at the bone itself? Thank you for diving deep with us today.